Thank everyone for joining us today. This is our second group webinar for the late pulmonary effects from childhood cancer therapies. And I should probably amend the name because it's not just childhood cancers, it's all kinds of autoimmune and immune dysregulation and all kinds of stuff that we end up doing, and people get bone marrow transplants or other types. So this year, next slide, Jenny. We have a really great session. We're going to talk about, we have an oncologist perspective on what of all these patients that we have, pulmonary, and then we're going to learn a little bit about chemotherapy and interaction, which I'm excited. Dr. Ajay Shashadri is an adult pulmonologist, so he can tell us what he sees in the adult world. Jason Wyman's going to tell us a little bit about imaging, and then we're going to have Dennis Stokes, who's kind of I'm not going to put any terms like grandfather, but you're the one who got me involved with this, and Colin told me a little bit that I should do this. And he's going to bring it home with his perspective after his awesome ongoing career in late effects. And then, so I'm Sam Goldfarb for people who don't know me, and I'd like to introduce Jenny Pichung Chang, who is an awesome pulmonologist and a great person who has also agreed to help co-chair this group starting about a month ago when she helped me organize this and get it going. So I'll let Jenny, you can do the next slide, and I'm really looking forward to this session.
Thanks, Sam, and thanks everybody for joining us today. So this is our second year of doing this webinar, and I think we just had so much fun last year and learning so much from everybody that we really wanted to bring all of these awesome speakers here today. And speaking from mentors who train the next generation, Sam has trained me. And so we hope that we will continue to give this trend forward and kind of help with education in the pulmonary and stem cell transplant world. So anyways, for our interest group, for anybody who is interested in joining us, we are going to be meeting at ATS this year. We meet yearly. And so this year it's going to be on May 20th, very early in the morning at 6:45 to 7:45 a.m. But it is also Pacific time. So hopefully we'll capture some of you guys. So if you guys want to come and say hello, for those that are already in the group. And if you're not and you're interested, my email and Sam's emails are listed here. I will put that in the chat as well so that you guys can jot it down and let us know if you want to join this group. Okay. So I will stop sharing and then we'll start our session today. I'm going to have the first moderator hop on and enjoy the session, everyone.
So hi, everyone. Welcome. My name is Brandy Johnson. I'm a pediatric pulmonologist at the University of Florida. I have the pleasure today of introducing Miss Lena Shahab, or Dr. Lena Shahab, excuse me, who will be detailing the oncologist perspective to the treatment of childhood cancers and survivorship outcomes. Dr. Shahab is an instructor of pediatrics at the University of Pennsylvania School of Medicine and an attending physician in the pediatric oncology division at the Children's Hospital of Philadelphia. She earned her medical degree from the Medical College of Virginia and a Master of Science in Clinical Epidemiology from the University of Pennsylvania. She completed her pediatrics residency training at the Children's Hospital of Los Angeles before moving to the Children's Hospital of Philadelphia for Hematology Oncology Fellowship. Her clinical care and research focuses on long-term outcomes of childhood cancer survivors. So we welcome her and look forward to her talk.
Thanks, Brandy. Let me just share my screen. All right, today I'm just going to be giving a brief introduction and treating childhood cancer, and as well as the field of childhood cancer survivorship. So there are more than 17,000 children in the US that are diagnosed each year. So that works out to about 47 children each day. Cancer is the leading cause of death by disease in American children, and it results in around 1,800 kids each year. And as you can see from this figure on the right, the incidence has been slightly rising in the recent decades. However, childhood cancer is still relatively rare, and it makes up about 1% to 3% of cancers diagnosed annually in the US. There are many different types of childhood cancer. They are distinct from adult cancers that we see. This is a non-exhaustive list. The most common overall that we see is leukemia, followed actually by brain tumors. We do see a variety of different other types of cancers that I won't go into detail for time purposes, but they impact all different organ systems throughout the body. So liver, kidney, eye, bone, soft tissue. And again, they're very distinct from the adult cancers that are treated. And there is differences amongst ages in children as well, which I'll touch upon in the next slide. So the column on the left highlights children that are aged 0 to 14, and then adolescents on the right that are age 15 to 19. And what you see in the younger children is, again, acute lymphoblastic leukemia is the most common that we see, which is 26%, followed by brain tumors. And then there's a mix of others following that. So other blood cancers such as non-Hodgkin's and Hodgkin's lymphoma, bone tumors, AML, kidney tumors. And then if you look at the adolescent subgroup, it is a little bit different. So the adolescent group most commonly is Hodgkin's lymphoma, followed by thyroid cancer. And then you see brain tumors is still pretty high up there. And then there is some distinct ones that you don't necessarily see. We see them rarely in the younger subgroups, but things like testicular germ cell tumors, ovarian germ cell tumors, skin cancer such as melanoma. In our adolescents, the incidence rate is a little bit higher than in the children subgroup. However, overall, it is still, the incidence is still lower than in the adult population. So even though we're seeing this slight rise in the incidence of childhood cancer, our overall survival, as you can see from this figure, has improved significantly. The x-axis gives you the years, so starting in 1975 up to 2011, with the y-axis giving you the percent. And what you can really see is that the 5-year overall survival in children who are diagnosed with cancer from 1975 was 58%, and now has risen to over 80%. So we've really made a drastic improvement in how we treat these patients and how we care for them. And so to break this down a little bit further, this breaks it down by diagnosis. And so overall, you'll see, again, it's about 80%. But there are some diagnoses that have some pretty significant 5-year overall survival rates, most notably acute lymphoblastic leukemia, which is, again, one of the more common diagnoses we see, Hodgkin's lymphoma, and then Wilms tumor, which are all about at 90% or above. Overall, these rates look pretty good, and we've made significant strides in a multitude of things to get here. But I also do want to point out that there are still survival rates that are quite poor in some diagnoses. And so even though we've made these great strides, we do have some way to go as well. So how did we get here? There are a couple of things that have gotten us to this point. We understand the diseases that we're treating better. We understand their genetic makeup better. We have better modes of detection. We can detect disease earlier, as well as detect smaller amounts of residual disease, which may make us alter how we're treating patients. We've learned that multi-agent chemotherapy regimens are better at treating certain cancers than using single agents. We have now access to targeted therapies, as well as immunotherapies that target specific areas of the immune system that contribute or can train your immune system to fight the cancer. There have been improvements in surgical approaches, and then I think one thing that doesn't get mentioned as much that is equally as important is our advances in supportive care, using blood products to support our patients and really just working to prevent infections from happening. So using prophylactic antibiotics, antivirals, antifungals, and really working to treat infections quickly and monitoring our patients very closely. And so with, all of these survivors, with these improvements in treatment and supportive care, more and more childhood cancer patients are surviving. And so now there are over 500,000 pediatric cancer survivors in the US. So that ends up working out to about 1 in every 640 young adults between the ages of 20 and 39 are cancer survivors. I think something that's very startling is that 95% of our patients experience some sort of chronic condition by age 45. And this graph on the right kind of highlights that our patients have really significant long-term morbidity and mortality. And so by looking at this graph, just to orient you all to it, on the y-axis, there's a survival function. And on the x-axis, we have time since diagnosis. The yellow line represents the US population over time, and the blue line represents cancer survivors. So as you can see, the outcomes are really disparate between these two groups, with overall mortality increasing significantly over time in our survivor group. So what is contributing to these late effects? So the cancer, the location, the tumor type can contribute. The treatment modalities that we use contribute, and I'll get into that more moving forward. Not only the tumor genetics, but the genetics of the patient themselves can sometimes contribute. And the reason that I really bring this up is that no two survivors are the same. And just because two survivors have the same diagnosis and receive the same therapy doesn't mean that their long-term side effects or late effects that they experience are going to be the same. And so we really are evaluating these patients individually. So what are the different modalities that we use to treat childhood cancer that could potentially result in acute and late side effects? So we use surgery, as discussed previously, chemotherapy, immunotherapy, we use radiation therapy, and then some patients get bone marrow transplant. So each of these modalities has different acute and late side effects associated with them that require long-term monitoring by people who are familiar with these side effects. And I think people look at these in different ways, and you can look at them by disease, by types of treatment, by systems impacted. For the purpose of today, I chose to focus, because this is a pulmonary focused talk, I tried to focus on the pulmonary system specifically, but I will highlight a little bit more in detail. Oncologists are generally pretty familiar with this figure. He's our chemo man. We use it to treat our residents and our fellows. And really what I wanted to highlight here was that whether you're getting radiation, which you're seeing on the left-hand side, or chemotherapy on the right-hand side, there's side effects that affect every organ system within the body. But today we're going to focus a little bit more on the pulmonary side effects. So if you're getting radiation, that can impact the lung. And then there are certain chemotherapeutic agents that can also impact the lungs long term. So just to recap that, both radiation and chemotherapy can cause pulmonary late effects. And their risk is variable. It can be related to the dose of the radiation or chemotherapy that they got, the duration of the exposure, how old they are at exposure, in terms of younger age being a little bit of a higher risk because you're not only possibly contributing to the development of the lungs, but also the development of the chest wall and the rib cage, and that can also impact symptoms long term. And then other exposures and contributing factors we think about in our patients are any premorbid or comorbid conditions that they have. So do they have an atopic history? Do they have a history of asthma? Any health behaviors they may have, such as smoking, vaping, or smoking other illicit substances, and then any infections they may have had before therapy, after therapy, or during therapy. So who gets this therapy? We know that the radiation and the chemotherapy can impact the lungs. What patient populations are we thinking about? I think the classic one that I think about and a lot of people think about is Hodgkin's lymphoma. They get a chemotherapy traditionally that we'll talk a little bit about more, that can have long-term pulmonary side effects, but they are also potentially now exposed to radiation that can impact the lungs as well. It used to be more, the radiation that they got exposed to used to be more standard, everybody got it, and now that is not the case. We're trying to use radiation less and less in this patient population, but it's something that we always think about. Other conditions, other diseases that get radiation are some diseases that have metastasis to the lung. One of the main ones is Wilms tumor, but others can get that as well. You can actually get scatter from radiation to other areas of the body. So we think about this in patients that had brain tumors or brainstem radiation, patients that had abdominal tumors that required radiation. And then you can also get radiation prior to bone marrow transplant. And then chemotherapy, the chemotherapy we discuss, we see this a lot. We use them a lot in our liquid tumors. Some of the less common ones we do use in our solid and brain tumors. So I put this out there to say that a broad population of our patients are exposed to chemotherapy or radiation that could potentially impact the lungs over time. And so as an oncologist, how do we follow these patients? How do we know how to screen them? And one of the main sources that we use to help guide us is the long-term follow-up guidelines that are put together by a multidisciplinary group through the Children's Oncology Group. And for those who don't know what the Children's Oncology Group is, it's an organization supported by the National Cancer Institute that is devoted exclusively to clinical trials for child and adolescent cancer patients. It's made up of 200 children's hospitals across North America, Australia, and New Zealand. And so it encompasses a broad group of organizations and people who really put this guideline together as a resource for healthcare professionals who provide care for childhood cancer survivors. So we're using this as our backbone to help guide us in screening this patient population. And so just to give you the layout of the land, the guidelines are they're large, and they're split up based on the treatment received. And so I pulled out the treatment that directly impacts the lungs and how, as an oncologist, I would use this resource. So in the first column, this is for radiation. It gives you the therapeutic exposure. So if a patient is getting radiation to the chest, to the axilla, or to their entire body, total body irradiation, which we typically do for transplant, this is where you're screening the patient. And then over in the next column, you're looking at the potential late effects associated with this therapy. So things that we think about are pulmonary fibrosis, interstitial pneumonitis, restrictive or obstructive lung disease. And something that was new that was added this year was this risk of lung cancer in these patients. And so it's a further discussion that we're having on how to screen these patients better. And then the periodic evaluation gives you a guide onto how you evaluate these patients. So of course, you're going to get a very good history for these patients, knowing that a lot of these things can be very subtle. And sometimes patients can even have changes on screening that they didn't necessarily notice day to day and may show up on PFTs. But we're doing a good pulmonary exam. And the recommendation here is to get pulmonary function tests at the entry into a survivorship clinic. So these patients, if they're getting radiation that could potentially impact the lungs, we're doing pulmonary testing, at the beginning of treatment, prior to radiation, and then after, but really following these tests moving forward. And if there's any symptomatic change, reviewing them and getting new PFTs for these patients. In terms of the lung cancer recommendation, that's more, this is something new that was added and has become a discussion between provider and patient for the risk versus benefits of this screening, and really trying to do this in those patients who are at highest risk, so who have had exposure to pulmonary toxic therapy, but may also be smokers or have environmental exposures that could make them at higher risk. And then this last column is, how do we counsel these patients? What are other things that we should consider for this patient population? So touching on, the tobacco use, environmental tobacco exposure, making sure these patients are vaccinated against things like pneumococcal and influenza, and then other areas we should be considering, repeating PFTs in certain situations. Things that I don't have highlighted here that we also take into account, which I touched upon a little bit earlier, are, patient-specific factors such as their age when they got radiation, the radiation dose that they got, whether they got a radiation dose with a chemotherapy that could also impact the lungs, whether they have those pre or comorbid conditions, and then specific health behaviors. So here's some more same kind of view, but now transitioning to chemotherapies that can impact the lungs. So we consider alkylating chemotherapies that can have long-term late effects on the lungs. And those include the ones in the column on the left, so busulfan, carmustine, lomustine, and melphalan, and their primary late effect is pulmonary fibrosis. So the patients who receive these chemotherapies were doing very similar screening to what I said for the radiation. We're doing a good history, pulmonary exam, and they're getting their PFTs regularly. And these are patients that, we typically use these chemotherapies in patients who get transplanted. So they may get the concurrent total body irradiation as well. So they're a patient population that we're following pretty closely. And then the second type of chemotherapy that we think about that can have pulmonary side effects associated with it are bleomycin. I spoke about, Hodgkin's lymphoma, and that being a classic diagnosis that we think about that can have long-term pulmonary toxicity. And they are the predominant diagnosis that get this medication. And again, a lot of our patients who got this chemotherapy did get some sort of radiation that could impact the lung as well. And so we're screening these patients closely, looking for long-term side effects, including things like pulmonary fibrosis, interstitial pneumonitis, and again, acute respiratory distress syndrome, which is very rare. But same sort of periodic evaluation and screening guidelines. And I touched upon, the radiation and the chemotherapies that we use in our transplant patients. But there are guidelines as well to follow patients in transplant who have any signs of chronic graft versus host disease related to the therapy that they got, related to the transplant specifically that they got. The potential late effects that we see in this patient population are things like bronchiolitis obliterans, chronic bronchitis, and then bronchiectasis. And they're getting very similar screening as our prior patients that we discussed. I will say that at CHOP, we do regularly get PFTs in these patients, even if they're asymptomatic. We typically screen them every 5 years. Just because we know that this patient population is at high risk as well for long-term late effects from that perspective. And then something that I think, you know, a lot of people don't necessarily think about are that any patients who have had any sort of thoracic surgery and the healing process that occurs in that setting, and the pulmonary dysfunction that can occur from that. And so we are closely screening this patient population as well, in a similar way that we would our other patients. I do have some honorable mentions that don't make the guidelines, but that we have seen late effects in. Brentuximab is a newer medication, is a newer chemotherapy that we've started to utilize in the pediatric population. There is data in adults where it has caused pneumonitis, but it is a serious cause of respiratory failure in that patient population. So we are watching specifically our Hodgkin's lymphoma patients pretty closely for any of these potential side effects. Cyclophosphamide and methotrexate are chemotherapies that we use in a broad way. It's used in many different diagnoses, and it falls under the same families as the chemotherapies I discussed previously. So the alkylating chemotherapies and anti-tumor metabolites, and they can also cause long-term pulmonary side effects. And then one thing that I always think about are residual fibrotic mediastinal masses. I've had patients who we've treated for Burkitt's lymphoma, primary mediastinal B-cell lymphoma, where their mediastinal mass was large, and it just became fibrotic with therapy. It didn't completely resolve, and they had some long-term pulmonary symptoms associated with the location of their masses.
And Dr. Shahab, I think we're at conclusion. I just wanted to give you a 2-minute warning.
Yep. And so in conclusion, I just wanted to highlight that, you know, survivors of childhood cancer are a really unique population. They have unique needs and we have unique health problems. And so while the overall outcome is good, there are short and long-term side effects of therapy that need to be monitored very closely, more so in some patients than others, depending on the therapy that they got. But with appropriate, I think, follow-up and research, we can put interventions into place to hopefully prevent and reduce the occurrence of these long-term sequelae of therapy that we see. And that's it.
Awesome. Thank you so much. That was a wonderful introduction to the program today. With all the amazing improvements in cancer treatment and survival rates, I really think this highlights a strong need for multidisciplinary care for these patients. So I look forward to seeing what our other speakers have to say in regards to that. And then if anyone has any questions for Dr. Shahab, you're more than welcome to include them in the chat, and then we can try to get to them at the end of the program, or if you'd like to hang around to the end and ask those at that point.
Okay. That was awesome. Who's going to introduce Courtney?
Yeah, so thanks so much, Dr. Shahab. Next, I'm going to introduce Dr. Courtney Gushu. She is going to be giving the pulmonary perspective of the intro to late effects of pulmonary complications of childhood cancer therapy. So a little bit about Dr. Gushu. She's a pediatric pulmonologist at Nationwide Children's in Columbus, Ohio. She's the associate program director for the Pulmonary Fellowship, and she sees a wide range of patients with particular clinical and research interests in those with neuromuscular disease, sickle cell disease, and complications from cancer therapy and bone marrow transplantation. So thank you so much, Dr. Gushu, for your time, and we look forward to your talk.
Thanks so much, and thank you guys for the opportunity to speak today. I'm going to get things pulled up here. All right. And are the slides showing okay right here?
Yes. If you want to put it in the presenter mode.
There we go. All right. Well, thanks again for the opportunity. Again, I'm going to sort of give an introduction from a pulmonary perspective to some of the late effect pulmonary complications of cancer therapy and sort of lay the groundwork for some more detailed presentations to come following. I think, though it's not the highlight of our talk today, hard to talk about late effects without first talking about what the other is early effects. So just to sort of think about how we categorize things, immediately during or after cancer treatments, we may see from a pulmonary standpoint some of the complications and sort of like the days, weeks, months during and after start of treatments for cancer, including things like pulmonary infection, pneumonitis, maybe even things like pulmonary edema and fluid overload, and in some cases, something like ARDS, possibly related to all of these aforementioned conditions. So while that's not going to be the focus of today's talk, something that it's important to at least keep in mind as we move on to, again, thinking about the late pulmonary effects. And so for the purposes of today, and really when we think about late effects, generally we think about more than 5 years post-treatment, though depending on where you're looking or where you're reading about things, you may see things that are sort of in a sooner range, a couple of years or maybe even months after treatment. But for the purposes of my introduction today, we'll be talking about 5 years post-cancer treatment. We know that the late effects of late pulmonary effects specifically increase over time, the further you are out from treatment of cancer, and the most common causes of death in survivors of childhood cancer include cancer recurrence and secondary malignancies. Behind that, though, cardiopulmonary complications, which is really kind of the crux of it all and why we're here today, right? Meeting as a group to talk about these complications. So again, great news that we have more treatments and more survivors, but really it's kind of our duty as, at least, from a pulmonary standpoint, to investigate these things and learn how to screen for, treat, and hopefully prevent some of these diseases. We actually know that the late mortality for childhood cancer survivors exceeds the expected rate estimated from the age and sex matched U.S. population. And that we're, as Dr. Shahab mentioned, really going to see more toxicity among survivors of these listed cancers here, as she went over. Some of the data that we'll kind of look through today shows that there's actually sort of a lack of plateau in seeing these late effects. And again, it sort of points to the need for ongoing research and really research and awareness into adulthood and including, adult pulmonary colleagues like we have on our call today to help us recognize and treat some of these conditions. Again, I'm not going to go over everything in detail, as Dr. Shahab gave us a great introduction to some of these things, but thinking about the contributing factors to who's going to develop these effects. As mentioned, it may be cancer-related, treatment-related with specific adverse effects that we know about, and then again, patient-related. So one of the things that I also want to highlight here when we think about some contributing factors from a patient-related standpoint are things like smoking exposure. We're doing a lot of counseling here, not just to the patients, but to the household members. And then other things like health habits. And what's really important to think about in things like having regular physician follow-ups, check-ins outside of just the long-term follow-up clinics, and also things like exercise. And we all promote exercise, particularly for cardiopulmonary health. But a lot of the survivors here are actually affected and complain of activity intolerance or impaired ADLs, including things like general activities or even physical activities that may play a role. So is there any role for pulmonary rehab or things like that in this population? As was already mentioned, we know the main treatments for childhood cancer include chemo, radiation, surgery, and stem cell. I'm going to leave it to our upcoming speakers to go into some of the more details about this, but these are some of the kind of prominent and more commonly reported late effects that we think about. And really, when we see these kids in our clinics or on consultation in the hospitals, it can be difficult to figure out what's going on sometimes, as a lot of the manifestations for the pulmonary late effects may present as some of our other pulmonary diseases that are common in childhood or adolescence, like asthma. So people might be coming in with dyspnea or chronic cough. Some of them might have reduced gas exchange or supplemental oxygen needs. And then some of our findings might actually be incidental, as we've seen that we're doing some screening in this population. What do we do when we see incidental findings on a CAT scan or a chest X-ray or even some pulmonary function testing? So some more to come in future talks on sort of how we screen for these things and recommendations moving forward in things like pulmonary function testing in this population to look forward to. And again, to highlight what I mentioned earlier, some limited exercise capacity that some of the groups have studied, and we'll go into detail here in a few slides. So a lot of what we know about the survivors of childhood cancer and sort of what kind of effects they have down the road come from the Childhood Cancer Survivor Study, or the CCSS. And this is a major study that was based out of St. Jude Children's Hospital in Memphis. And it's led by Dr. Greg Armstrong, was the PI for this study, who focuses on neuro-oncology and survivorship. And so this is a really important study that was funded by the National Cancer Institute of the NIH. It's a retrospective cohort study that actually was able to look at over 38,000 survivors of childhood and adolescent cancer who were diagnosed between 1970 and 1999. And with it being multi-center, there's over 30 centers participating, which really led to the robust nature of this study that's really given us so much of what we know about this population. What's also important to note in this study is that there's over 5,000 siblings of survivors who are used for the comparison group in these studies. And the way the study worked was a lot of surveys and questionnaires were sent to survivors or families of survivors if they had already died. And we were able to use, or not we, they were able to use this information to sort of put forth a lot of publications that's able to help a lot of different specialists in caring for these populations. So as I'm going through the remainder of my talk, you'll see that I've pulled out a lot of charts and diagrams from certain publications in this study. I personally didn't contribute to this study, but I'm highlighting things as we go because, again, it really contributed so much to what we know about these diseases. So it's hard to really talk about pulmonary late effects without referencing some of these big studies. So we know there's sort of 3 impactful publications that have commented on pulmonary complications of childhood cancer here. So the first one was back in 2002 with Ann Mertens, published in Cancer, the pulmonary complications of survivors of childhood and adolescent cancer from this study. Further, in 2013, Dr. Huang and colleagues presented or published on the pulmonary outcomes in survivors of CNS malignancies, also from this report. And then again, a follow-up 2016, there's another publication, as you see here, from Andrew Dietz and the rest of the group on the risk and impact of these complications. So I'm going to sort of go through these 3 publications to set the stage over the next several slides. So first, with the 2002 study, this again is a self-report of conditions with the objective to determine the incidence rate of the pulmonary effect by time period, which I'll talk about, and compare that incidence rate to that of the sibling cohort. And here, when we think about the time periods that they described, they sought finding pulmonary diagnoses or conditions that occurred first prior to diagnosis. And then the 3 kind of treatment timelines that they talked about were diagnosis to end of treatment to 5 years, and then 5 years and beyond treatment, really that late effect group. So again, this first study looked at over 12,000 survivors and 3,500 siblings. And what we learned from here, there were 3 subjects underwent lung transplantation, and overall there was over a 9-fold risk of pulmonary related death among the 5-year survivors in this group. There was also noted to be across all 3 of the treatment and beyond period an increased relative risk of these conditions. So things like fibrosis, recurrent pneumonia, chronic cough. You can see the whole list here, and we'll sort of break these down over the next couple slides. When they looked specifically at the late effects, so those beyond 5 years post-treatment, what they noted was that there was a statistically significant increased relative risk of developing lung fibrosis, supplemental oxygen needs, recurrent pneumonia, chronic cough, and pleurisy. And then there's a breakdown by each treatment that had a significant association with each of these outcomes. This table is taken from this publication, and I'm just, as I mentioned, going to highlight a couple things to make it a little bit easier to walk through for presentation's sake. And for here, we're looking at the relative risk of these reported conditions compared with the sibling cohort. And what you'll see is in this table, the rates are reported during the first occurrence by time group, so in each of these columns. And so these aren't listed as cumulative incidents, and that's why you see some of the later time period, the numbers look a little bit smaller. And so what they saw was that the highest rates of diagnosis of pulmonary conditions was first noted during that diagnosis to end of treatment window, but they continued to have more diagnoses as time went on that we'll talk about. So of these, when we think about it from a cumulative incidence standpoint, they noted that 4 conditions, so lung fibrosis, chronic cough and shortness of breath for greater than a month, pleurisy, and exercise causing shortness of breath, all had the highest rates of cumulative incidence. And so they put this together really nicely in some graphs on this slide. And what you see here is on the y-axis is the cumulative incidence percent of these conditions, and on the x-axis is the years since diagnosis. And a couple abbreviations to point out here: CRX is chest radiation, and then PTC is pulmonary toxic chemotherapy. And so they broke this down by exposures. So for these 4 conditions, those who received both pulmonary toxic chemo and chest radiation had higher incidence percents of developing these 4 conditions. And I think it's interesting to note on these graphs here that you actually see the those who had chest radiation only actually had a similar cumulative incidence to these findings as those who got both treatments. And then those who received the pulmonary toxic chemotherapy had similar rate of incidence to those who received neither treatment. So it's interesting to sort of point out in these graphs. Following this up in 2016, Andrew Dietz and colleagues published again on the risk and impact of pulmonary complications in these survivors, and really sought to describe again that sort of 5-year and beyond survivors comparing to siblings, and then also assess what kind of associations with daily physical activity limitations there were reported in this group. And so here there were a little bit higher number of survivors and siblings noted, and again it was survey-based self-report here. And this is another table from this particular study that shows looking at the frequencies, incidence rates, absolute excess risks, and incidences of these conditions. And what I'll point out here is the absolute excess risk noted for the survivors here. And compared to siblings in the control group, there was higher absolute excess risk for chronic cough, supplemental oxygen need, lung fibrosis, and recurrent pneumonia. They also noted in this study that at age 45, the cumulative incidence of any pulmonary condition was 29.6% in survivors and 26.5% in siblings. So almost 30% had a pulmonary condition at that time. This is depicted a little bit differently. I think it's a little easier to see in graph format here. But again, I've highlighted in yellow the 4 conditions we're talking about here with elevated cumulative incidence. And what you see is the solid line depicts the survivors, and then the dashed line depicts the siblings here. On your y-axis, you have, again, the percent cumulative incidence, and your x-axis is age in years, so not time out from treatment here. And again, you can see the disparities between the survivors and the siblings for these conditions here. And interestingly, you'll note here that asthma actually had sort of the reverse findings. So siblings were more likely to have asthma than the survivors. You'll note again from this study, looking at the pulmonary mortality cumulative incidence by years since diagnosis, and you'll see that there's a standardized mortality ratio of almost 6, with statistically significant associations with platinum-based medications and increasing doses of chest radiation. And if you recall, the standardized mortality ratio is that ratio that quantifies increased mortality of the study cohort, which is our survivors, with respect to the general population, or in this case is our sibling cohort. And then the last thing noted in this study here was looking at, again, the associations with physical activity limitations. So what they did when they were looking at this is they sought to say, so of the survivors who have asthma or chronic cough, how many of them are reporting activity limitation compared to the siblings with the similar condition? And so the only statistically significant finding in this analysis was actually that survivors with chronic cough had a higher odds ratio of reporting activity limitation than that of siblings. There was an increased frequency of activity limitation reported for those with oxygen needs and recurrent pneumonia, but these weren't statistically significant findings. I think it's also important to note that in this analysis for this study, they did adjust for things like sex, race, attained age, and then, of course, smoking status, stem cell transplant status, amputation, paralysis, and congestive heart failure, because as you can imagine, all of these things impact reports of physical activity limitations. So lastly, I'm going to sort of close out with the third study, or the third publication that came from this study looking at survivors of childhood CNS malignancies. And here you see there's actually more siblings included in this report than survivors. And again, it's the self-report of conditions. And here, again, they sought to determine the associations between craniospinal irradiation, or CSI, and pulmonary dysfunction. And as you'll see, a number of associated pulmonary conditions were reported. And I'll highlight here in red that survivors had higher rates than siblings of pulmonary fibrosis, abnormalities of the chest wall, chronic cough and shortness of breath, and again, a need for supplemental oxygen. I'll also point out from this study that they highlighted those who received craniospinal irradiation had a 10.4 times more likely report than those who weren't exposed to CSI to have deformities of the chest wall. So something that's really important to keep in mind in this patient population. So in conclusion, again, as we both mentioned now, it's great that we have increasing survivors of childhood and adolescent cancer, but with that comes really this increasing incidence of complications. And it's our responsibility and our due diligence to continue to meet in groups like this and continue to investigate these outcomes, how we screen for them, and hopefully how we can prevent them moving forward. So with that, I'm going to thank you all for your time and move on to the next speakers.
Thank you. I would like to next introduce Dr. Takuto Takahashi. He's my countryman and completed pediatric residency in SUNY Downstate Medical Center. And then he joined pediatric hematology oncology fellowship at the University of Minnesota, where he also completed his PhD in experimental and clinical pharmacology with a focus on PK/PD modeling and pharmacogenetics. He then joined Dana-Farber Cancer Institute in 2021 as a stem cell transplantation fellow before he became a faculty member in 2022. His research focuses on application of PK/PD modeling in stem cell transplantation. He's currently running long-term follow-up clinic for his pediatric stem cell transplantation and patients. We're very lucky to have him speak today. So Takuto, please take it away.
All right, well, thank you so much, Leo, and thank you, organizers, for this great opportunity. I'm Takuto Takahashi, one of the faculty members from Pediatric Stem Cell Transplantation in Dana-Farber Cancer Institute and also Boston Children's Hospital. I'm very excited today to talk about this topic that is very close to my heart, chemotherapy-induced lung toxicity in hematopoietic cell transplantation. I have no disclosures. So I first want to make sure that we are on the same page and we share the same picture of the landscape regarding what is important for our patient and what is important for us, transplantation physicians. So this is the statistics from the National Registry, CIBMTR, on the causes of deaths in transplantation patients divided into the pediatrics. Oh, sorry, let me see if I can do the pointer. So the top is pediatrics, the bottom is adults, divided into different time frames, less than 100 days on the left and greater than 100 days on the right. So as you can see, the distributions of these causes are sort of mixed in all these 4 different pie charts. But you can probably tell that the 4 common causes are the same, regardless of the age or the timing of the data, where the data was taken from. And based on this data alone, you can say that chemotherapy-induced lung disease should be a diagnostic exclusion because we do not want to miss something like infection, which is this one, or GVHD. And it is because we do not have any great way to diagnose that this is chemotherapy-induced lung disease without excluding these other differential diagnoses. This is also the same data from the same registry group. Now we are looking at different chemotherapy agents that are commonly used in transplantation. It is called conditioning chemotherapy. It is a type of chemotherapy with or without radiation that is given about a week to 10 days immediately prior to the date of transplantation. So we are looking at the data for AML and MDS in the United States for the recent time period. So the go-to regimen in pediatrics is by far MAC or myeloablative conditioning regimen that is much more intense as compared to reduced intensity conditioning RIC or non-myeloablative regimen. And as you can see, blue, which is busulfan cyclophosphamide combination or busulfan fludarabine combination. So these are the busulfan-based regimen. That's the majority in our patient population. This landscape looks very different when you shift your eyes to the other counterpart, which is acute lymphoblastic leukemia or ALL. Again, from the same time period. And similarly, the go-to regimen is MAC. So the majority of the pediatric patients receive TBI, that's orange, TBI-based conditioning regimen. It is very often combined with cyclophosphamide. So you can assume most of your acute lymphoblastic leukemia patients should have received TBI combination combined with cyclophosphamide regimen immediately prior to the transplantation. It is important because what we just saw was regardless of your diagnosis, like AML, MDS, or ALL, the most common regimens include one or the combination, like more than one of these three agents. Chest radiation, well, TBI is a total body irradiation, so you expose patients to radiation, the whole body, including the lungs. Busulfan and cyclophosphamide. And according to the data from childhood cancer survivor study, these are the three, some of the three main causes of the late lung effects in childhood cancer survivors. So it is important to recognize that. So let's look into the mechanism, like why these chemotherapy agents cause lung effects or like lung injuries. Looking at the busulfan first. So busulfan can cause lung injury by two main mechanisms. One of which is intra-alveolar edema. So busulfan can stimulate type 2 alveolar cells, leading to aberrant surfactant secretion, increased surface tension, increased suction pressure. That leads to intra-alveolar edema, and that's a vicious cycle. And the busulfan can also lead to more like chronic long-term interstitial fibrosis through this pathway of activation of CD8 T cells and cell apoptosis and inflammation. Cyclophosphamide, on the other hand, is a well-known oxidative stressor, along with other alkylating agents or radiation, and that can contribute to lung injury that has been shown in mouse model. And as a matter of fact, because it shares the same pathway or same toxicity pathway as other alkylating agents and radiation, those are the sort of additive risk factors if you have more than one of them. So this is a recent report from our group in pediatric stem cell transplantation in Dana-Farber. So our group looked at more than 300 patients over a period of 10 days who got transplantation for leukemia or MDS. And then they looked at different kinds of pulmonary toxicities, including supplemental oxygen use, pleural effusions, airway infection, or predicted if FEV1 less than 60%. So what they found was the median FEV1 decreased at 1 year post-transplantation as compared to the baseline before transplantation. And that was true for both TBI cohort, the radiation cohort, and busulfan cohort. And also, if you look at the composite pulmonary toxicity endpoint, about a third of the patient at some point through the course had a lung event. But as you can see, like most of them happened in the first 6 months after transplantation, and not so many occurred afterward. If you only look at the fatal pulmonary events, that was 66% in both cohorts. So there was no difference between the busulfan-based conditioning cohort versus radiation-based conditioning cohort. So that's the message. And looking at different data sources. So this is all pediatric and adult combined, looking at the incidence of idiopathic pneumonia. This is a little bit older study, but still useful and informative, I think. So this is a randomized control trial comparing oral busulfan combined with cyclophosphamide versus TBI cyclophosphamide regimen. The incidence of idiopathic pneumonia was relatively high, up to about 16 to 18%. This number came down to less than a half when you look at the national registry data over 2000 to 2006. So this is a big data. So they compared the IV busulfan cyclophosphamide versus PO busulfan cyclophosphamide in TBI Cy regimen. And all of the number dropped significantly. I think part of the reason is probably in this early cohort, the diagnosis of idiopathic pneumonia was not so easy. Well, I should say the diagnosis of infectious pneumonia was not so easy, such as CMV pneumonitis. Nowadays, it's so easy to do CMV PCR, and that can exclude CMV infection from this cohort of idiopathic pneumonia syndrome, but that may not have been as easy as it is right now in this time period. And also the TBI, the use of TBI has been improved by using the fractionation technique or lung shielding sometime, I think, over this time period. And both of them contributed to the drop in the instances of the idiopathic pneumonia syndrome. And this may not have been statistically significant, but you can also see that IV-based busulfan may have led to a lower incidence of lung event as compared to the PO event, PO busulfan regimen. And more recently, this group just compared IV busulfan, that's what we only use nowadays, versus TBI. The incidences are similar, 4% and 6%. Just similar to what we just saw in our Dana-Farber data, there was no major difference between the busulfan-based regimen versus TBI-based regimen when it comes to the lung effects. So now I want to delve into the more like busulfan chemotherapy-induced lung-led effects. That's something that is close to my heart. So busulfan is a drug that is primarily metabolized by the liver enzymes such as glutathione S transferase 1. It has less PK variation when it's given by IV as compared to PO. It has a very strong exposure response associations, which I'm going to talk about in the next slide. And it has, again, a very narrow therapeutic window. I'm going to talk about it. As a result of all these reasons, the National Society of Transplantation recommend the routine clinical use of PK study, the intensive PK study with dose adjustment in order to attain optimal exposure in all of the patients. So this is a landmark study that was conducted by Bartlink and published in Lancet Hematology in 2016, looking at the optimal exposure of busulfan in more than 600 patients aged less than 30 who received various busulfan-based chemotherapy regimen and transplantation. What they found was, so there was a sweet spot somewhere around the AUC of 90, total AUC of 90. And that's the exposure range where you see the lowest event, well, this is actually opposite, lowest event of any adverse outcomes. And when you go a little bit high on the AUC, you will see more toxicity-related deaths. And if you go a little bit low on the exposure of busulfan, you will see more inadequate control of the disease, which is disease relapse, or graft failure, which is also associated with inadequate exposure to the conditioning chemotherapy. So it is very intuitive for transplantation physicians. And when you compare these groups, so green is the optimal cohort that achieved the sweet spot and that attained the best event-free survival. And whether you go a little bit too high or a little bit too low, so that's a blue and yellow, your outcomes are not as good. So the takeaway from this study is the target AUC is very narrow. It's actually like 90 plus minus 12%, which is not possible without doing those adjustments. And as I said, if you go too low, you will see adverse events. And if you go too high, again, you see different kinds of adverse events. And it is important to note that optimal exposure for lung injury, as far as I know, has not been shown or has not been even studied in any study. And this is, I think I can just walk through this quickly. So this is what we do in our clinical practice. So in order to attain optimal busulfan AUC, we do multiple sampling after the first dose of busulfan, usually somewhere around the 4 to 6 time points. And we calculate AUC from the single dose, and we project the total 4-day AUC. And when the total 4-day AUC is outside of the target range, we make those adjustments for the subsequent doses. And we repeat this process usually like 2 or 3 times through the 4-day course of busulfan. And more recently, there are some institutions that use so-called model-informed precision dosing, using a dedicated software and taking advantage of a population PK model that enables limited PK sampling. So you can only sample the 2 or 3 time points, and you can do very good estimation of the AUC, possibly better than the traditional AUC estimation method. And you can do something similar, project the total AUC over 4 days and make a dose adjustment in order to get the optimal exposure at the end of the 4 days. So just shifting the gears a little bit, I want to spend the last few minutes to talk about alkylating agent exposures. So in acute lymphoblastic leukemia, so these are the recent or the current regimens, protocols from the childhood oncology group and different risk groups. Regardless of the risk groups, the only alkylating agent you will receive is cyclophosphamide at a dose range of 1,000 milligram per square meter to 3,000. So what this means, when you have a patient who got transplantation for acute lymphoblastic leukemia, he or she must have received some level of cyclophosphamide before transplantation, which can range from maybe at the minimum 1,000 if this patient had refractory disease and was taken to the transplantation immediately. But it could be much higher if that patient had an initial good response and completed initial leukemia regimen, then went on to have a relapse disease, received a relapse regimen, and eventually came to transplantation. So it is important to look at the total exposures and before the transplantation. And I'm gonna wrap up in the next few minutes. It is very different in AML or mild leukemia because they don't get any alkylating agents for the most of the regimens that I know of. So you don't need to take into account the alkylating exposures before transplantation. You do need to look at the busulfan and cyclophosphamide because that's the most common combination chemotherapy for conditioning for transplantation. And maybe I can just skip this one to finish, not to go over time. These are conclusions. But thank you for your attention. I'm happy to take any questions.
Thank you, Takuto, for the impressive talk. I was under the impression that we might try to cluster the question towards the end, Dr.
Okay. I may not be able to stay. I apologize. If it's possible, I'll stay or I'll come back.
Yeah, we can forward any questions that anybody would have for Dr. Takuto, but feel free to put the questions in the chat room. He may be able to answer when he's available. Otherwise, I'll forward it to him after.
Thank you so much.
Thank you, guys.
Thank you very much. Looks like there's some work to do with busulfan and understanding lung injury with area under the curve. So that's something for the future. Hopefully not too future. Anyways, our next was a great talk. I think we're pretty close to being on time. We're only 7 minutes off, so I think we got a great first hour, and the second hour is going to start off awesome. We have Dr. Ajay Sheshadri. I hope I'm pronouncing your name correctly. Associate Professor of Pulmonary Medicine at the University of Texas, MD Anderson, and who focuses on infectious and non-infectious complications of stem cell transplant. He's a special interest in the implementation of home spirometry for screening for bronchiolitis obliterans syndrome, or lung GVHD. Also advanced imaging techniques to identify early BOS, and then mechanisms of epithelial metaplasia that are associated with irreversible pulmonary impairment, along with BOS-specific biomarker development. He's received NIH funding as a PI for his work and also works as a co-investigator on ongoing trials for the Lung GVHD Consortium. And he's also a key member of our monthly group and gives us the adult perspective of pulmonary complications. And we're going to ask him to talk a little bit about lung function testing in the adult population. So once we've transitioned them, and some sites still do, I think at CHOP, they were transitioning in their mid-20s. So I'm curious to hear what happens after we send them to you guys.
All right, and thank you for having me. Hopefully it's sharing properly. I'm Ajay Sheshadri. Thank you for that awesome introduction, Sam. I'm going to be talking about late pulmonary function testing, and it's going to focus a little more on adults as well as post-transplant, but I've tried to also include as much pediatric data as possible, as well as to kind of give a broader impact for pulmonary function testing. So a little bit about the general principles of pulmonary function testing after hematopoietic cell transplantation. So these are from recent guidelines from the adult data from the NIH chronic GVHD working groups. And for adults, they recommend pulmonary function testing prior to transplantation, and then again at day 100, and then at least at that point, 1 year after transplant, and then every year thereafter. And then in patients with chronic GVHD, primarily to detect for lung GVHD or bronchiolitis obliterans syndrome, PFT should be done every 3 months. And there's really not a specific end date for that. And a lot of this is focused on the early detection of BOS and other lung function complications. Similarly, in kids, there was recommendations that came out very recently, and this is an international guideline, so several BMT organizations came together for this. And they recommend in general that at every evaluation, there's an assessment for pulmonary symptoms, with the caveat that early BOS often does not present with symptoms, but perhaps pulmonary symptoms can be a herald of other lung conditions that are not necessarily BOS. And then to do pulmonary function screening every 3 months for the first year after transplantation, every 6 months in the second year, then annually for 5 years after hematopoietic cell transplantation. So this again helps us monitor for lung conditions that happen in the very early part of transplant, but then it doesn't help us too much with understanding what happens well into the future after transplantation. And then finally, PFTs at the initial diagnosis of chronic GVHD similar to adults, and then spirometry every 3 to 6 months until there's discontinuation of therapy for GVHD. So this helps us with some of the upfront complications of transplant, but unfortunately, it leaves a big gap in knowledge because as patients start to survive the complications of cancer by undergoing hematopoietic cell transplantation, it does not necessarily guide us on how to manage and how to detect long-term pulmonary function impairment. So we have some gaps in knowledge, and this is again focusing a little more on transplant, but how often do late pulmonary complications of transplant occur, particularly those that occur 5 years or later? What is the value of lung function testing to detect these complications? How often should we do it? And how long should we continue to measure PFTs in transplant patients? So I wanted to take a step back and talk about why we care about lung function at all. Why is it important for us to measure lung function in patients in general? And from the adult perspective, we have some interesting data because pulmonary function testing is an incredible biomarker of overall health. It's not just a marker of respiratory disease, but it's even a marker of things like cardiovascular disease. So drops in vital capacity are associated with a higher risk of cardiovascular disease. And this was demonstrated really well in the Framingham study, where they examined over 5,000 non-smoking adults. And those who had an FVC of less than 85% of predicted, so corrected for age, sex, and height, and then perhaps race as well, although it's a little more controversial, they had an increased risk for cardiovascular disease. And this is seen in multiple studies all around the world. So this is not a US specific phenomenon. In Germany, for example, each percent increase in FEV1 and FVC was associated with substantially lower mortality after median follow-up of 5.5 years in German individuals that are aged between 35 and 75. So adults, but a very broad age range. And similarly, in the ERIC study, higher FVC was associated for better survival, and there may even be a sex-specific difference here where it's more protective for women. So in general, higher lung function long-term is associated with survival, and these are generally healthy people. We don't really have great long-term data in cancer survivors, but it's likely that these effects are, if nothing else, even more magnified in cancer survivors. And why do we care about lung function in kids in particular? So there's a couple of reasons that I think that this is doubly important. And the first is that just kind of common sense, kids have the longest to survive after their cancer. You're talking about several decades that they have to live with any potential impairment. And we have specific data with regards to how this might impact their adult life. If you look at patterns of lung function trajectory over time, those who have reduced growth have a higher risk for COPD and other complications. And those who have reduced growth who also have a decline, so they have a second hit down the road, for example, perhaps they take up smoking as an adult, they have the highest risk for COPD. And this is shown from the CAMP study that was published in 2016, this particular study. And it shows really nicely that if you don't attain a normal maximally attained lung function, you are at a much higher risk for complications down the road. And so this is doubly important for children because the risk window is much longer as compared to, say, somebody in their 60s or 70s. I'm going to talk a little bit about pulmonary impairment in the setting of chemotherapy and kind of the data that we have in adults and partly in kids as well. In general, we can take the concept that chemotherapy intensity is associated with pulmonary impairment, and this is seen across several cancers. So, for example, in over 1,000 survivors of testicular cancer, higher dose chemotherapy was associated with a higher likelihood of pulmonary impairment, as well as restrictive lung disease. This is also seen in patients with stage 3 non-small cell lung cancer. Usually the median age here is in the 50s and 60s, but higher dose thoracic radiation is associated with a greater risk for pulmonary impairment. And this is similar to seen in even breast cancer survivors. So chemo and radiation dose intensity predict pulmonary impairment. And this is seen in a couple of different studies, including one that was published very recently. And then bleomycin, we know quite a lot about. And bleomycin and thoracic radiation are both associated with lung impairment in patients with Hodgkin's lymphoma as well. And I'll show you a couple of slides that highlight that. This is from an abstract that was presented at ASH last year. And this looks at patients who had Hodgkin's lymphoma who were treated with either AVD or ABVD, where bleomycin is added to the chemotherapy regimen. And the red is in ABVD. And you can see that the long-term follow-up, the diffusing capacity is around a little more than 5% lower than in patients who didn't get the bleomycin. And so in these patients who did not get bleomycin, they generally had a return to normal lung function. But in those who received bleomycin, the return was impaired. And you can see that the number of long-term survivors that were measurable also declines substantially after 5 years. So I think this speaks again to the need to focus a little bit on these long-term complications. And just kind of pulling back the camera even further here, when we just look at childhood cancer survivors in general, they're much more likely than healthy controls to have symptomatic and asymptomatic lung function abnormalities. So this is looking at all cancer survivors from City of Hope. The incidence of restrictive lung disease was nearly 25%, and the incidence of diffusing capacity abnormalities was over a third. And this is compared to 5% and 10%, which is about what you'd expect in general if you just measured the lower limit of normal in these patients. So it's almost 3 to 5-fold higher in cancer survivors. And so this speaks to a need in general that we need more data to understand, one, what is the incidence of pulmonary function abnormalities? How are these manifesting? Are these interstitial lung disease? Is this subtle injury to the pulmonary circulation that won't show up on a CT, but will show up on pulmonary function testing, and perhaps with some newer imaging modalities? And then what is the impact on life long term? So these are yet unknown. I wanted to talk a little more about pulmonary function in the setting of hematopoietic cell transplantation as well, too. And I'll talk about both adults and children. So this is kind of a typical course for hematopoietic cell transplant pulmonary function. So it's not uncommon to see a drop in pulmonary function in the first few months after transplantation. And usually by month 6, it starts to recover. By 1 year, it's getting closer to normal. And there is a slow recovery over time. These are in patients who receive busulfan cyclophosphamide, but no TBI. And this is specifically looking at diffusing capacity abnormalities, but these do tend to get better over time. And of course, those who develop lung GVHD generally don't have recovery, and that's not surprising. But in those who don't develop a lung complication like that, in general, there is some capacity for lung function recovery. In the setting of TBI, that changes things quite a bit. So this is in a study that was about 20 years old now, of 200 hematopoietic cell transplantation recipients. 83 of them survived to 5 years, and 69 had pulmonary function testing, and most of these had TBI. And you can see that with the addition of total body irradiation, there's a lot more patients who had lung function impairment. So they defined a lung function impairment as a greater than 5% decline in FEV1. And they found that within the median follow-up of 7.5 years, 45% had a 5% decline, and 17% of these had developed pulmonary symptoms in addition to the impairment as well. The main predictor of this was pre-transplant pulmonary function testing that was abnormal, as well as chronic GVHD. So this suggests that with the addition of TBI to treat the cancer, there is long-term impairment that can occur. Pulmonary impairment may depend on some other transplant factors as well. This was a study that was published around the same time too. And one of the challenges is that the transplant practices changed so much over time that when you're talking about 10-year follow-up, the transplant practices may change quite a bit. And therefore, what was true 10 years ago may not be true now. But this is looking at data from about 20 years ago. And this is looking at 109 patients who underwent mud transplant with or without ATG. And 51% of patients who did not receive ATG developed chronic lung dysfunction. And this is kind of loosely defined as FEV1 decline, not necessarily as BOS. And in the non-ATG arm, FEV1 and FVC declined by about 20% over the study period, which is 2,500 days. Whereas in the ATG arm, there was, if anything, a slight recovery, although not significant. And though lung volumes were mostly not done, they thought this was mostly kind of a restrictive pattern. Lung function impairment is also common in some modern cohorts. This is a study that was published a couple of years ago from Japan. And they looked at 201 first transplant recipients that were followed over 10 years. 84% of them received myeloablative conditioning, and 59% developed TBI. So 41 of these patients developed lung function impairments, about 25% of those that were observable at 10 years. 21 of these were not due to NIPCs or non-infectious complications, and 20 were due to non-infectious complications. And just diving a little bit about the types of injuries that happened, you saw obstruction that increased from 7% in 2 years to almost 20% at 20 years, and then restriction, which increased from about 7% in 2 years to a little over 22% at 15 years. And the interesting thing is that obstruction, even though it was commonly seen, was not as impactful as restrictions. So restrictive lung abnormalities were associated with a hazard ratio of 7 for mortality. And this is similar to some of our own data that we've seen at MD Anderson that we've only published in abstract form so far. When we look at long-term follow-up greater than 10 years, this is a study that was also published relatively recently, and they looked at 100 transplant survivors that had a median survival of 17 years after transplant. About 33% developed chronic GVHD, which is about what you'd expect. just based on the epidemiology of GVHD, and 7% had TBI. And just focusing on those without BOS, because we know that BOS is going to impact things like FEV1 and FVC. So just focusing on transplant recipients without BOS, those patients that did not develop BOS still had a lower lung function than healthy controls. 1/3 of them developed impairment, and in particular, the type of pre-transplant chemo increased the risk for long-term lung impairment. When you look at the types of lung impairment that we found that we were seeing in the study, 4% had restrictive lung impairment and 17% had impaired diffusion. But interestingly, 48% had some form of HRCT abnormalities. So this might just be the tip of the iceberg, and it's hard to know what to do with these interstitial lung abnormalities that are often seen on CTs, but the long-term natural history of these is not known. When looking at a recent study looking at the CIBMTR late effects cohort in adults, this is a study that was led by Stephanie Lee, looking at over 4,000 or almost 4,000 adult transplant survivors. Pulmonary late effects occurred in about 12% of patients with GVHD and about 11% without. So almost the same with or without GVHD. And the late effects here, they defined as COP, alveolar hemorrhage, interstitial pneumonitis, ARDS. And then, the other group also include things like COPD and IPF, but these were excluded from the analysis because they were not as common. So it's more of the NIPCs that we often think of. CGVHD in particular was associated with late effects. Now, this study did not report on lung function trajectory, but this is a study that from Hemang Yadav at Mayo Clinic, and this does show very nicely the lung function trajectory in patients with and without BOS. So this is almost 1,200 patients from the Mayo Clinic. These are first transplant recipients. They had longitudinal pulmonary function. And in patients without BOS, the FVC declined by about 6% in the first 6 months. And then at 5 years, there's about a 12% decline. Oops, sorry. And then FEV1 about 14% and the DLCO about 10% at 5 years. And their models show a pretty continuous decline. And so the error bars are not in this graph, but you can see that it's a pretty steady decline from 0 to 5 years after transplant. And we don't know what happens really after 5 years because there's only a few studies that look at the very late effects of transplantation. And then late onset interstitial lung disease is something that's also being increasingly recognized. And so this is from Anne Bergeron, who's one of the preeminent BOS researchers who's now in Geneva. And she published this just last year and was looking at late onset ILD. And the exact incidence is not known because what they did is they took 79 patients from their center between 1981 and 2019. And they looked at interstitial lung disease, which was mostly organizing pneumonia. And ILD was more commonly associated with symptoms compared to BOS. And this is one of the paradoxes about BOS, that you can lose a lot of lung function without developing symptoms. But these ILD patients were often symptomatic. And one of the biggest risk factors for this was thoracic radiation. So again, going back to not just TBI, but to radiation in particular, some of these peri-transplant injuries that occur as a consequence of consolidation and as a consequence of irradiation have some late effects with regards to ILD development. I wanted to talk about a couple of studies in kids as well, too. And so kind of going back to the theme of this symposium, looking at long-term pulmonary function impairment in pediatric transplant survivors. This is a study that was published in 21 by Auth and others. It's 142 survivors of childhood cancer undergoing transplant with a median follow-up of 9 years. And 51% had some abnormality beyond 5 years post-transplant. So it's hard to know if these were existing before baseline, in part because there was only a few that had baseline PFT. But overall, the FEV1 Z-score declined from -1 to -1.7. So, on average, many patients had pulmonary impairment by that criteria. The risk factors, again, included thoracic radiation, but also things like relapse, which we do see that as a factor for lung impairment. And of course, that's a little bit different in the sense that that's associated with more serious implications of the cancer itself, but also female sex. And this is just some of the lung splines looking at the long-term lung function data. Of course, there's a lot of variation in the natural history for an individual. And then finally, this is from Samini Srinivasan, who's part of our special interest group as well, looking at 308 transplant recipients aged 6 to 21. And 120 of these had normal PFT in the first 10 years after transplant, but 188 had at least one abnormal PFT. Of these, less than half had pre-transplant pulmonary function abnormalities. So in other words, more than half of these patients who had abnormal PFTs developed it as a consequence of transplantation. Patients with pulmonary complications were less likely to recover lung function to normal, and this persisted even if you adjusted for the pre-transplant FVC. So some of the events that happen after transplantation can also impact the recovery. Chronic GVHD, again, was a significant factor for whether lung function recovery happened or not. And the moderate to severe FEV1 impairment were also associated with these pulmonary complications. And again, why do we care? I think this is probably the best study that highlights why we care about long-term lung function. And it's that non-recovery of pulmonary function is associated with long-term impaired survival. This is exactly what we see in adults as well, too. And again, this is a single center that showed this, and it highlights the need to study this in a more comprehensive fashion. So I have some quick conclusions here, and then we'll take questions at the end. But I wanted to highlight that lung function impairment is common in long-term survivors of transplant and cancer in general, actually. Impairments in the transplant setting are often due to chronic GVHD or TBI. Thoracic radiation specifically might be associated with impairment. But again, just thinking of this in a more broader context, the more intense the chemotherapy and the more intense the radiation, the more likely that you're going to have pulmonary impairment. The current guidelines recommend pulmonary function testing up to 5 years, and after that, the guidelines are really not clear. And of course, as Sam and I can attest to, the adherence to pulmonary function testing is not perfect from center to center, and so it's something we can all work on. And just in general, we need more information on the long-term pulmonary function outcomes as cancer survival improves. Thanks, everybody, for your time.
Thank you very much for such a great talk. I think unless there's something burning, we might have to move on just to keep people on time and try to be done more or less on time. Jenny, who's introducing our next speaker?
Dassis.
Yeah, hey, how are y'all? Hi, it's my honor to introduce Dr. Jason Weinman. Dr. Weinman is a pediatric radiologist at the Children's Hospital of Colorado, where he is the director of body and thoracic imaging. He's currently the chair of the Thoracic Imaging Committee of the Society of Pediatric Radiology, and has been a part of the Child Network and Imaging Working Group since 2014. He's authored over 35 papers on pediatric lung disease. I personally have learned a lot from Dr. Weinman's perspectives on imaging and lung fibrosis, so I'm really excited about this talk. Dr. Weinman.
Great, thank you very much, Das. And I think actually this talk dovetails pretty well with the Dr. Shahard's previous talk, as we get to see some imaging examples of some of the things that he talked about. So I've been asked today to talk about the late pulmonary imaging effects of cancer. I do have a couple disclosures. I'm a reviewer of fibrosing lung disease in children for CALEX. I also am on the advisory board and receive non-financial support for study pediatric fibrosing lung disease from Boehringer Ingelheim. I think this has been covered a lot, so I've kind of limited my background slides. As we've talked about or previously, the survival rates for childhood cancer have improved, with the overall survival rate now 80% and approximately 420,000 childhood cancer survivors in the US. The late mortality for child cancer survivors exceeds age and sex matched controls, also has been previously discussed, with leading causes of death being malignant neoplasm, pulmonary, and cardiovascular complications. Late pulmonary complications, I think there's different definitions, as we've sort of talked about here. For this talk, we'll talk about complications that occur 100 days after cancer treatment. And late pulmonary toxicity is most common in patients who've received chemotherapy, radiation therapy, or have undergone a stem cell transplant. So we'll look at sort of a time scale, and I think that's helpful for us when we're imaging to kind of know what we're concerned about. At 3 months, we start to see organizing pneumonia forms of graft versus host disease. This, of course, overlaps with early complications of cancer treatment, including infection. 6 months, we start to see bronchiolitis obliterans. 6 to 12 months, chemotherapy and radiation-induced fibrosis. 12 months, rarely, we see air leak syndrome. And much farther out, around 8 years, we start to see pleural parenchymal fibroelastosis and secondary neoplasms. So first, we'll talk a little bit about organizing pneumonia. It's a form of graft versus host disease, which are complications following allogeneic stem cell transplant, where the donor T cells recognize the host as foreign, leading to immune response against the host. There's an increased incidence with leukocyte antigen mismatched stem cell transplants, older recipients. peripheral blood-derived stem cell grafts, and it can affect any organ in the body. Organizing pneumonia, formerly called BOOP, frequently presents with cough, fever, and dyspnea. There's a mean onset of about 3 months, then therefore, as we talked about, overlaps with early complications and infections, and can occur in isolation or with bronchiolitis obliterans. So really, it's a multifocal process characterized by organizing fibrosis of loose connective tissue that includes the distal airways and alveolar spaces, hyperplasia of types 2 pneumocytes lining the alveolar septa, with mild to moderate interstitial thickening consisting of lymphocytes and plasma cells, and foci of endogenous lipoid pneumonia. This study by Feria looked at imaging findings in organizing pneumonia. Most common was multifocal ground glass opacities and consolidation. Of course, this can overlap with infection. Reticulation, nodules, perilobular opacities, reverse halo or atoll signs, which we'll see examples of. Airspace nodules and halo signs were also seen. So here we have an example. This is a 24-month-old whose status post-BMT for neuroblastoma with increasing O2 requirement, multifocal ground glass opacities throughout the chest bilaterally on both the coronal and axial reconstructions. It turned out to be bronchiolitis obliterans. Here we have another example. This is an 8-year-old, 3-month status post-BMT for X-linked lymphoproliferative syndrome. We have multifocal areas of consolidation. We have tree and bud opacities with central lobular nodules. We also have some areas of interlobular septal thickening, most prominent at this right lung base, and turned out to be bronchiolitis obliterans. This is the finding, I think, that's unfortunately relatively rare. I think it was about 17% in that study, but is sort of the classic finding for organizing pneumonia. And I think I might have misspoke on the prior slide about organizing pneumonia, but is this sort of reverse halo or atoll sign where we see sort of a ring of opacity with more preserved central lung architectural, and that's an atoll or reverse halo sign. It's a classic finding for organizing pneumonia, unfortunately not frequently seen. Next, we're going to talk a little bit about bronchiolitis obliterans. It's the most common form of graft versus host disease in the lungs following allogeneic stem cell transplant. It occurs in 18 to 14% of children following allogeneic stem cell transplant. The mean onset is 6 to 12 months. It's a fibrosing chronic obstructive disease, and the signs and symptoms include tachypnea, cracking, crackles, wheezing, and hypoxemia, and it has an indolent onset. So pathology, we see near complete obliteration of the airways with residual mucosal epithelium, epithelial fibrosis, and a peripheral rim of smooth muscle. The CT findings of bronchiolitis obliterans, we see mosaic attenuation, areas of air trapping, and these findings are really, it's really important to have expiratory images in these patients, as these findings can be accentuated, and in some patients only seen on the expiratory images. I think that's an important consideration when ordering these tests, to know that that's what we're looking for, because I think that that's a very those are very useful images to add, and some places have moved away from doing them routinely on high-res chest CT. Additional findings, less common in bronchiolitis obliterans, include bronchiectasis and bronchial wall thickening. I think this kind of represents a problem. As we're learning radiology, we're sort of taught to look for bronchiectasis in association with air trapping to suggest the findings of bronchiolitis, to suggest bronchiolitis obliterans. And in these BMT patients, I think actually the bronchiectasis in our experience has been pretty rare. And I think that makes it a challenging diagnosis. And here's an example of a patient with bronchiolitis obliterans on the inspiratory chest CT on the left-hand side of the screen. We see relatively clear lungs. We don't see, maybe if you, with a little bit of imagination, you might think that the lung density is lower than normal, but that can it varies with age, so that can certainly be challenging. On a limited axial expiratory image, we can see mosaic attenuation, where we see the more normal lung increases in density on expiration, whereas the areas of air trapping, the lung remains relatively loose on these expiratory images. This finding is suggestive BO in a BMT patient, although you could have this finding with bronchiolitis of infectious causes or asthma as well. So again, the expiratory images are very helpful to evaluate for air trapping. Some of the problems with this is can be anesthesia or patient dependent, depending on if the patient's under anesthesia or their compliance with instructions. We've seen patients with really severe BO where the air trapping was so diffuse that it just made it look like there was sort of relatively poor expiratory effort. We weren't really able to see the mosaic attenuation because the areas of air trapping were just so diffuse. And it really does rely upon those differences in attenuation, differences in air trapping to accentuate the findings. It's also very difficult to quantitate the change over time and timing of CT. One way we've sort of looked to address this is to do 3D reconstructions on our CTs in patients that were concerned for bronchiolitis obliterans. We use Thur Recon. It's just a 3D tool, and it lets you set a threshold attenuation value above and below which you can quantitate and in different colors accentuate the areas of decreased lung density. And here's an example of this in a patient with BO on their pre-transplant with a threshold value of -900. We see what looks like relatively normal attenuation throughout the lung, shown here in pink. Keeping that same threshold value as the patient's disease progressed, we see increasing areas of relatively low attenuation throughout the lungs. On subsequent CTs, this increases more. Again, we're keeping the values, the threshold value the same over time to help accentuate so that we can see this change and even following. And this is a pattern that we would see in patients with that we were concerned for bronchiolitis obliterans syndrome. Another patient, again, this was one of their initial CTs. We do see some areas of relatively low attenuation on their initial chest CT, but increasing over time, shown in green, where we have increasing areas of low attenuation suggestive of air trapping inconsistent with bronchiolitis obliterans. So issues with doing this, we know that the lung density in pediatric patients change over time, especially in young patients. We'll go from an attenuation in our youngest kids of -400 to -500 to an attenuation of around -900 in adult patients. Anything that increases the lung density, such as pneumonia or edema, can cause sort of errors or confusion in the interpretation of these scores. It also depends on the degree of inspiration, how big of a breath you took while the CT was being acquired. And then the threshold's empirically selected. So the numbers have a relative change in the numbers is helpful in making the diagnosis, but it's not meaningful in and of itself. So here we have an example. This is a patient that had known bronchiolitis obliterans syndrome, went on to have a viral infection. We see ground glass opacities throughout the chest consistent with the viral infection. And you can see when we do a 3D map in this patient, now we see those areas that look like infection, ground glass opacities show up as darker pink. We still have areas of air trapping, but this sort of confounds the interpretation. One way to address this is a technique called parametric response mapping. It uses dual-phase inspiratory and expiratory CTs with a voxel by voxel comparison of the lung attenuation change between the co-registered inspiratory and expiratory CTs. It generates a PRM functional small airways disease value with that PRM FSAD in patients with BO compared with control patients, increased in patients with BO compared with patients with infection alone. Patients with bronchiolitis obliterans syndrome had similar PRM FSAD profiles, whether they had infection or not. And here's sort of a diagrammatic representation of this, where you use those paired inspiratory and expiratory volumetric CTs. You do sort of a heat map of the comparison. You then use a classification model where you have an area that represents parenchymal lung disease, such as we saw in an infection in that prior patient, functional small airways disease, normal lung or emphysematous lung, and then you can use that classified value to give a rating for their degree of functional small airways disease. Unfortunately, this is requires sort of specialized software that's not available at many institutions, including ours. We'll go on. We'll talk a little bit about chemotherapy and radiation-induced fibrosis. They have non-specific presentation with dyspnea and non-productive cough. The onset varies with chemotherapy agent or method of radiation delivery, but usually over 6 months with variable progression. It's more likely with higher cumulative doses of chemotherapy, radiation greater than 15 gray, or a combination of radiation and chemotherapy. There's varied histopathologic findings, including UIP, desquamative interstitial pneumonia, or nonspecific interstitial pneumonia. Imaging findings include volume loss, architectural distortion, parenchymal bands, traction bronchiectasis, reticulation, and honeycombing. And we'll see a few examples of what these findings look like in patients in adult patients with UIP, not patients necessarily that have undergone cancer treatment, where here we see honeycombing, where we have clustered enlarged air spaces with stiff fibrotic walls. You see these rounded areas of relative lucency with thickened walls, and that constitutes honeycombing, pretty rare for us to see in pediatric patients. This is a reticular pattern in a patient with findings concerning for UIP in an adult, and here we have a crisscrossing network of opacities in the periphery of the lung with dilation of the small airways, bronchiolectasis. Also, one more adult patient. This patient has traction bronchiectasis. They also have honeycombing at this left lung base, where we see reticular opacities associated with dilation of the small airways, and that's traction bronchiectasis associated with reticulation, again, in a patient with UIP. So here we have a patient with a refractory relapse pre-B-cell ALL status post-BMT. This was one of our patients from our hospital, albeit an older patient, in November of 2023, a relatively normal chest CT. Just 3 months later, we see really diffuse findings with ground glass opacities throughout the chest. Superimposed on these ground glass opacities, we see a similar sort of crisscrossing network of reticular opacity superimposed on that. We also see dilation of the airways associated with those reticular opacities. So we have areas of reticulation. We have traction bronchiectasis, and the findings are consistent with fibrosis. That same patient, about a month later, we see sort of relatively decreased ground glass opacities, those reticular opacities, and areas of airway dilatation, traction bronchiectasis remains concerning for fibrosis. That same patient, here we have just a magnified image where we see that reticulation crisscrossing network of opacities associated with dilation of the peripheral airway consistent with bronchiectasis. Next, we'll talk a little bit about air leak syndrome, relatively uncommon manifestation. It can suggest severe pulmonary disease. Risk factors include allogenic stem cell transplant, high-grade graft versus host disease, young age, and male sex. The alveolar injury can result in air extending into the interstitium, which results in interstitial emphysema and can lead to pneumomediastinum, pneumothorax, or subcutaneous emphysema. So here we have an example. So I think in the background of this patient, you see again the findings that we saw in that previous patient that are suggestive of fibrosis, where we have reticular opacities with associated dilatation of the airways, consistent with fibrosis with traction bronchiectasis, but this patient also has air leak as a complication. We have subcutaneous emphysema within the chest wall. We have areas of interstitial emphysema where you can see gas extending into the lung interstitium. We also have small pneumothoraces bilaterally, as well as a relatively large pneumomediastinum. Finally, we'll talk a little bit about pleural parenchymal fibroelastosis. This occurs much farther, more around 8 years post-treatment. It was initially described as upper lobe predominant fibrosis in adults that progressed to respiratory insufficiency. It was initially reported as idiopathic in adults. More recently, it's been associated with prior BMT and radiation therapy, although it can also occur in patients who've undergone lung transplantation, have had an occupational exposure, infection, autoimmune disease, hypersensitivity pneumonitis, or have a genetic predisposition. In this study by Wen et al., they looked at 8 patients with pleural parenchymal fibroelastosis. The average age mean age was 12.9 years, and 7 out of the 8 had a history of cancer with chemotherapy and radiation therapy. 1 patient was idiopathic, and most were referred for lung transplant evaluation. The imaging findings of PPFE included bronchiectasis, septal thickening, pleural thickening, and platysthorax. So here we have a 14-year-old male who had a history of treated neuroblastoma as a young child, and we see these sort of linear and coarse opacities, probably parenchymal bands in areas of reticulation associated with dilation of the small airways or traction bronchiolectasis. We also have areas of pleural thickening. An axial image on that same patient, we see a parenchymal band where we have a thickened band like opacity extending to the lung periphery, as well as an associated area of pleural thickening. This is a different patient. This patient's findings are more diffuse than the previous patient. They don't have quite the upper lobe predominant findings. We see linear and coarse opacities, some of which may be associated with dilation of the small airways. We also have sort of some of these areas that look like parenchymal bands and or reticulation. We also have multifocal areas of pleural thickening, as well as narrowing of the AP diameter of the chest, which is platysthorax, and the findings are compatible with pleural parenchymal fibroelastosis. So in summary, with increasing childhood cancer survivors. It's important to recognize the imaging findings of late complications of cancer treatment. A combination of clinical findings and timing since treatment are critical to establishing diagnosis and help to direct patient care. Thank you.
Thank you, Dr. Weinman, for that wonderful talk. It is now my very great honor to introduce Dr. Dennis Stokes, who will very fittingly be finishing this session with a summary on what has happened and what future directions research in this needs to take. Dr. Stokes received his medical degree from the University of Kentucky and went on to do a pediatric residency at Johns Hopkins Children's Hospital and went on to do a fellowship in pulmonology at Boston Children's Hospital. He then came back to Johns Hopkins and he was also chief resident and was on the Harry Claims service. It is our good fortune he came to Memphis in 1982 first to St. Jude, where he headed the cardiopulmonary service before going on to Vanderbilt in 1990. He was then in Indianapolis as professor of pediatrics in the division of pulmonology before moving on to Dartmouth. And it was our very great fortune that he came back to Memphis in 2007 to head up the division of pulmonology here at Le Bonheur and at St. Jude. And Dr. Stokes has done extensive work in quality improvement in the field of cystic fibrosis, but more importantly, in the world of pulmonary complications from childhood cancer. Dr. Stokes.
Thanks, Salme. Let's see, where am I?
Dennis, are you able to find the share? Oh, there you go. We can see it.
Okay, good. It was a little bit.
No worries.
Well, thank you very much for including me. This has been a terrific session. Can people hear me okay?
Yep.
Yeah. Well, I was asked to sort of be follow the elephant stars for this and deliver some final remarks, and I was happy to do that. And like I say, it's been a great session. I did, as so many mentioned, I came to St. Jude in 1982. This is a young me with hair, and with Barbara Taylor, who was the longtime ICU director at St. Jude, and a wonderful person. The ICU at the time I arrived was 4 beds, and the ICU was a tiny place that and critical care for cancer patients in 1982, I can tell you, was pretty controversial. People didn't like to intubate patients, and it was my first experience being the cleanup person for the stars of the St. Jude universe who had patients who were admitted to the ICU. Fortunately, things have progressed a long way, and Ray Morrison and his group in critical care at St. Jude are now among the best in the world, and it's really an incredible unit at St. Jude now. I wanted to highlight one person that was very instrumental in the development of lung function testing at St. Jude for over 30 years. And this is a picture of Bill. Bill Backert started the pulmonary function lab at St. Jude. I also like this picture because a lot of our residents have never seen a real spirometer. So it's a good slide to show to people. This patient's name is Tony, and we'll talk about Tony a little bit later. He's actually was an early patient who got one of the first bone marrow transplants done at St. Jude. Bill was responsible for a number of early pulmonary function studies. He set up the pulmonary function lab at St. Jude. The lab was actually set up by Sam Sanyel, who preceded me as director of the ICU. And Sam was a cardiologist who developed an interest in treating pneumocystis, which was a major epidemic in the 1970s as ALL patients survived. And Sam and Bill published a study of lung function in pneumocystis patients, which actually showed pretty good recovery of lung function. We later also looked at varicella pneumonia, and again showed pretty good recovery of lung function in this group through of St. Jude patients. Lynn Johnson came about the same time I came in 1982 to start the brand new bone marrow transplant program at St. Jude, one of the first pediatric transplant programs in the country. And very quickly, we started to see patients with chronic obstructive airways disease. And Lynn has this paper, which includes lung function of post-bone marrow transplant. The other thing the paper has, which is somewhat unusual now, it was before we were able to diagnose bronchiolitis obliterans with CT scanning. So quite a number of those patients got biopsies, which led to some pretty complicated chronic leak syndromes. But there's some nice pictures of bronchiolitis obliterans in that paper. After I left in 1990 to go to Vanderbilt, one of my partners, Paula Bozeman, who was actually an adult pulmonologist who I had recruited to work in the ICU, along with Nasa Marina and the solid tumor group, published a very nice study of serial pulmonary function study in Hodgkin's, which I think is probably one of the first long-term pulmonary function studies. And again, Bill tested most or not all of those patients. Jumping forward to 2016, this is the St. Jude Life cohort study, which was headed by Dan Green, and Bill had tested most of the patients who were brought back for St. Jude Lifetime cohort studies of lung function. And this published in 2016 showed a high incidence of pulmonary function changes in this group of patients out over 20 years, predominantly with post long-term survival. I want to acknowledge we have a great group here in Memphis, including Neil Batt, who's not here in Memphis any longer, but he did do his survivorship fellowship. And more recently, I've been working with Neil on a follow-up study to that 2016 study, and it's been great to work with Neil, and we're starting to look at follow-up pulmonary functions to get some idea about longitudinal change in this interesting group. The survivorship group here is an incredible group. Dr. Carrie Ness came in around 2007, and we immediately bonded because of her background in cystic fibrosis. But she has an incredible human performance lab at St. Jude, which is really a remarkable group of folks interested in exercise and functional changes in St. Jude survivors, and we'll talk a little bit about that. Dan came to St. Jude from Buffalo, where he'd had a distinguished career in oncology, and again headed up the first pulmonary function study and involved in the follow-up study as well. Greg Armstrong is currently chair of the survivorship group and has a great vision for that group. Melissa Hudson, I've known since she was a junior faculty and has gone to have a stellar career in survivorship, and much of the work in pediatric oncology group she has been very involved in. Dan Mulrooney has also been involved in pulmonary function studies. The best gift I ever got from Tom Keynes was when he heard I was coming back to Memphis in 2007, said, "I have this great fellow, Samini Srinivasan, who you need to give a job." And I was really fortunate to have Samini join me when I came back in 2007, and she and Ashok was highlighted earlier, have done some great work in the transplant realm, transplant patients in terms of long-term lung function. I stole this from Greg Armstrong's. He's a new chair, but he gave a great talk about sort of laying out his vision. And these are the superb elephants that are at heading up the cancer survivorship group. And I would encourage you to go to the St. Jude website, maybe even give a little money to St. Jude. And then once you get through the fundraising, you can go to the website and read about the work that Greg, Melissa Hudson, and Carrie Ness are doing and have done in cancer survivorship. This group has a very clear plan for identification of high-risk population, characterizing the physiologic and genetic contributions to a variety of outcomes, including cardiac and pulmonary, and more importantly now moving on to translation of research and trying to improve outcomes and improve clinical practice, which where Kiri's group is really focused on now is developing interventions that hopefully can alter the outcome for lung function in this group. So I was asked to talk about some these issues, and most of this has been covered, so hopefully we can stay pretty close on time. I'm not going to go repeat some of the things that have been said. In terms of which group of patients need long-term monitoring, the COG guidelines are easily accessible. They're currently on version 6. Dan Weiner was the pulmonologist who was involved in setting up the COG long-term follow-up guidelines for pulmonary issues. So you know they are high-quality recommendations. And again, I won't go through this. Most of this makes sense for pulmonologists. And they do recommend pulmonary function testing for long-term survivors at baseline, and then depending on the results and later risk to have follow-up studies done. More recently, there were in the international field, there was a lot of discrepancy in terms of recommendation for pulmonary dysfunction among the childhood cancer group. And Claudia Cooney from Bern and Switzerland put together a large group of pulmonary experts, including Melissa, Dan, and Neil are also on this, along with me and Salmini. And this paper just got published. It's a Swiss watch of a paper. It's really an intricate paper with a large review of the literature. I urge you to look at it. And I think somewhat controversially, this international group, in terms of who needs surveillance for pulmonary dysfunction and what surveillance modality should be used, basically came down on the side of not recommending pulmonary function for asymptomatic at-risk cancer survivors. That's due to the lack of interventions to prevent progression of the asymptomatic pulmonary dysfunction. And so I'm not sure how this is going to be resolved between POG and the international guidelines, but there is this difference that's out there now, and we'll see how that is worked out. Obviously, as a pulmonologist, I'm always on the bias of getting pulmonary functions, but so one of the other topics I was asked to speak to was sort of anticipatory guidelines. This has already been discussed with the Children's Oncology version 6 guidelines. And again, those are easily accessible, and I urge you to look at those. Most large cancer centers now have survivorship clinics. The ACT clinic here at St. Jude was one of the first in 1984. And hopefully you have access to that. And the many oncologists now are developing an expertise in survivorship. So, but they are going to use the COG guidelines probably as their reference. This has been shown before from the COG guidelines, so I won't repeat these. For radiation and for and one of the nice things that's available through the POG guidelines are handouts that are more appropriate for patients and families rather than for healthcare workers. So these are also available through the POG website. I was asked to also speak to transitioning to adult pulmonary care, and I'm glad we had an adult pulmonologist involved. One of the reasons we started this interest group was to hopefully involve ATS adult pulmonary people, and because I think that dialogue with the adult people, they have a very different perspective on lung function and decline of lung function in age that. There are a number of barriers. This is, for the average pulmonologist who's not working in a cancer center, this is a relatively rare patient population. And as pointed out, we have a lack of proven effective therapies to halt the decline in lung function. So, and our studies are over long timelines of many years of pulmonary decline. And that's not generally the orientation of the average adult pulmonologist. Fortunately, there are a lot of good centers, adult centers that have a center of affiliated adult pulmonologists in Boston, New York, Seattle, and Houston, and you know who they are. This other issue is, are there therapy interventions to improve pulmonary functional outcomes? And again, I think this is an area where we're really struggling. This is one of Greg and Kiri's studies from 2019, which they looked at VO2 max in cancer survivors who were a mean age of 35 years, and they had VO2 peak values, what you would expect for 70 and 80-year-olds. And these low exercise function were independent predictors of all-cause mortality. And this paper associated a number of cardiopulmonary outcomes with poor outcome. And although she only included FEV1, and it was in this population was almost certainly associated with restrictive change rather than obstruction. It was an independent risk factor for mortality as well. So Kiri and her group are starting to look at interventions to develop practical rehabilitation interventions that potentially could have a role. Certainly exercise has the potential to improve pulmonary outcomes. Respiratory muscle training may have a role, and some populations, but I think we're going to need to do a lot more work on finding better in antifibrotic therapy, anti-inflammatory therapy, bronchodilators, the traditional medical therapies. I'm not sure is going to have much effect, but probably need more studies. Well, the cancer therapy, as it's been pointed out, is constantly evolving, and newer chemotherapeutic and immunotherapeutic agents and newer radiation techs are constantly evolving. So there's never going to be an endpoint where we are not identifying new risks. So this is going to be an ongoing problem. An ongoing challenge. People have brought up more sensitive pulmonary function techniques like multiple breath washout, whether these could have a role in assessing lung function, and there's certainly a need to do that. The longitudinal change and, as was pointed out, the accelerated lung function decline with aging is something that I think is of interest to all of us, and the adult people have a lot of experience with looking at accelerated lung function decline with aging. It's somewhat impractical to do pulmonary function testing in the lab for some of these patients, but many of you are familiar with the Zephyr home spirometer, which was used a lot in cystic fibrosis during the COVID pandemic. And I know in some transplant patients, home monitoring of lung function may be very helpful. You know, most of the reported studies have talked about obstruction and restriction, but as was discussed previously, there are a number of other abnormal lung function classifications that are recognized in the adult literature. This is from the ATS-ERS revision of pulmonary function interpretation. And nonspecific or preserved ratio impaired spirometry is clearly associated with bad outcomes in adult populations through the COPD genes study and other studies. And how common that is in our population, it really hasn't been looked at. There are other mixed disorders that have been described again in adult populations we haven't really looked at. Dysynapsis, there was a nice review recently in the Blue Journal on dysynapsis. I'm not going to spend a lot of time on that, but it's an interesting, again, pattern of lung function that may be associated with outcome and be important in the cancer population. I just want to point out one other thing in terms of the new guidelines for classification of severity, which use Z-scores, are divergent from the common terminology for adverse event from the NCI, which had traditionally been used to classify severity of lung disease in this population. So resolving how these work out, I think it's going to be one of the challenges that we're facing as we're looking at the longitudinal study in St. Jude Life. And I think it's going to be interesting to see how these new definitions and recommendations from using Z-scores as opposed to percent predicted affect our classification of lung disorders in this population. One of the things that we recently I learned about from our radiologist at St. Jude was photon counting CT imaging, which is this incredible advance in CT imaging and if you look that up and look at some of the new lung imaging using photon CT imaging, gives incredible images of the lung, even better than high resolution CT with lower radiation. And I think that's going to be a major advance. Even St. Jude doesn't have a photon counting CT device at this point, but those things are coming. I'm surprised nobody discussed hyperpolarized helium MRI for bronchiolitis obliterans, but and again, that's not very well available for most centers, although last year at ATS, I saw the first commercial hyperpolarized helium MRI system. I tried to get St. Jude to buy one, but they didn't have $1 million laying around to do that. Well, there are new baseline risk factors. Obviously there are genetic risk factors and potentially some lung function risk factors that I think we will work out in the future. I would advocate as pulmonologists that we should argue that everybody should get a routine lung function test as soon as they can if they're over age 6, because I think that baseline lung function may be very important. There is one study because of the St. Jude Lifetime cohort, patients get the whole genome sequencing data. This is really one of the first studies to look at genetic influences that may have predict restriction. And this is from Cindy M., who's now in Minnesota, and that reference is out there. The guideline, harmonization guideline, again, is a very complete document. There is lots of information there on knowledge gaps, and I won't go through this long table, but there's plenty plenty of gaps here to address in the future. And I think there's plenty of work to do. So thank you very much.
Thank you, Dennis. That was awesome. I really liked listening to it. I guess if people are around and are interested in asking any of the speakers questions, they can. I understand it's 11 minutes after the hour, so I won't be offended if people decide to go on to their next task. Since
Dennis,
we're-
There is a
And-
question in the chat.
yes. So I think Claudia, I'm gonna not pronounce Claudia's last name correctly. Cooney, is that correct?
Good.
Wanted to comment to Dennis, when you were talking about the screening guidelines, she had said all pulmonologists in an international team would probably tend to recommend for pulmonary function testing, including her. Which I think most pulmonologists, oh, Claudia's on, so if you
Yeah,
want to.
we had long discussions, but like the international guidelines have a very strict way to make recommendations and as actually also to assess all papers for bias. And really what we found is absence of evidence rather than even for agents like bleomycin, where we know how the mechanisms is and that it is harmful. So the papers were very heterogeneous and really difficult, often retrospective data, often when you did all these bias assessments, they would not suffice the criteria. So actually, what I also want to encourage is I think we should do more testing longitudinal, and we should to know better what we need to do or not. And I would, all the pulmonologists would have tended like to suggest at the time where we know so little, we should really do a lung function test. It's very non-invasive and relatively cheap. But that was the way the guidelines were built and are being, there is a consensus of what we then can recommend. And the main thing actually was really also because there is no intervention we can offer to cure if we find something.
Yeah, the issue of no intervention, I think, is the key. I mean, why do you do a test if there's nothing? But I'm hopeful that maybe some of the work on exercise, pulmonary rehabilitation may offer a rationale for.
Jules, you had a question. We're going to ask Dennis about blebs.
This is a great session. And this may be a very rare problem, but have any of your patients ever asked your permission to go scuba diving? And if they have you, what kind of imaging do you get before? Just a plain chest x-ray or a CT scan? Do you have any thoughts about that?
Yeah, not a sort of post-transplant. It comes up quite a bit with sort of asthma. And I used to dive in my younger years, and there are some guidelines for that. But I have some hesitancy for. I think if there's any evidence of any lung dysfunction, probably imaging is at a minimum what you would want to do. So
Yeah.
I don't know. Yeah, it was interesting, the scuba guy. We have to ask Dan Weiner. Dan was on the POG guidelines, and it must have come up in those discussions about scuba diving.
I'll have to look those up. Yeah.
There's been a lot of discussion about dysynapsis, and you and I know that came out of Mary Ellen and Jerry's work, and I'm sort of torn about is that going to be how important it's going to be, and there's actually some data in adults that dysynapsis is maybe a real thing, and
Oh, yeah.
Do you have thoughts about that?
Yeah, I mean, I think that that in those studies in the New England Journal, it looks like it's very much related to the rate of decline of lung function. If you have dysynaptic growth and development of COPD, you're more likely to have, I guess, gold level 4 COPD. So yeah, I think that was a real practical outcome from those studies that Jerry Mead did with Tom Martin, and yeah, I agree.
Okay, variation.
Yeah.
I talked to Sanja Stanjevic about this a little bit, and she pointed out that some of the imaging correlates of dysynapsis don't necessarily follow dysynapsis assessed by expiratory studies. So but with some of these new CT imaging, it's pretty interesting to look at airway parenchymal growth, and so and as the radiation dose comes down, that could potentially be a tool to assess.
Yeah.
Jules or Dennis, can you guys talk a little bit about the synapses for some of the learners on here in terms of kind of the physiology of what's happening in the airways? Do we expect more obstructive lung disease, resistance, just so that we can learn a little bit about it and what that might imply in the chemotherapy and radiation patients?
Well, there's a nice review, Steve Adman. I can send that to you. I won't go through it. It's and again, this came out of work showing variation in flow volume curves, and some. I think Jerry Mead was the first. There's differential growth of airway and parenchyma. So, and that may have an effect. It sort of died for a long time, but has had a rebirth. And again, I'm not sure we know how significant it's going to be. And we've had some discussion at Vanderbilt, because the question is, do you put it as a pattern of abnormality on your PFT interpretations? And I guess I have some problems with that, because I'm not sure it can be a normal variant. So we don't. But the person who did it's not Steve Adman who's the first author, but Steve's on there. So it's a very comprehensive review.
I mean, the original observation that Jerry Mead made was just that adults with identical vital capacities can have vastly different flow rates on their flow volume curve, peak flows and mid flows. And the most practical marker that is used to follow it now is the FEV1-VC ratio, because the FEV1 is a flow rate and the vital capacity is a volume. So it gives you an idea of whether there's a discrepancy between the rate of growth of flows and volumes, or airways and parenchyma.
I always think so hard when Jules teaches me.
You don't have to think that hard.
He's taught a lot of us over the years.
Nah.
What do you mean, no? Look behind you. Isn't that the tree?
I just said the
Oh, yeah.
Your disciples and
Yeah, sorry, that's obnoxious. I didn't realize it was there.
No.
So you have your own tree?
Yeah. Dennis, you have a much bigger tree.
No, I don't. Well, no, I'm part of Mary Ellen's tree. And
Yeah.
although I gave my tree diagram to Paul, who is hanging in his office now. So yeah, you have quite a tree of your own.
This is the Mary Ellen tree diagram.
Whoa.
Yeah, I'm on the right upper lobe.
Yeah, right, exactly. I'm in the right middle lobe, I think. You can see the glasses. The glass is broken. I have to get the glass replaced, but it's still up there. It's dangerous. Right now, it's just dangerous. This is a great session. All the speakers, I learned so much.
No, it was wonderful.
I have one question, if there's no one more, I don't know if there's any other questions. Does anybody, I don't know if Ajay or someone can comment a little bit more on just the restrictive lung disease pattern, seeing how it's much more, it's got an increased mortality rate on the adult side. And is there anything, like what are some of the etiologies that you think can explain the restrictive lung disease? And are there any treatment plans? Is it really non-reversible? Like, I mean, I've had restrictive lung disease that I can explain and I can try to see if I can reverse it, but I also have restrictive lung disease that you don't see anything on imaging. And is that just permanent? Is that on the, like you said, the endothelial vascular side of things? Is there anything that is reversible that we can do as pulmonologists on either side, pediatric or adults?
Yeah, I think that's a great question, and it's pretty timely because we're working on a manuscript that's looking exactly this, because you know, I think there's a concept that restriction immediately implies a pulmonary abnormality, and you know, I think your mind immediately might go to interstitial lung disease or pulmonary fibrosis and these other things that we commonly associate with restriction. But you know, restriction is pretty common after transplant, and you know, pulmonary disease is of course probably the most obvious reason for it, but there's a lot of other things that can cause it. And so we sort of just took a look, in part because when you look at post-lung transplant restriction, in many cases that indicates allograft rejection with the restrictive allograft syndrome. And there's some schools of thought that applies to the post-transplant population equally, which we felt was not the case because we really don't see a lot of the same post-transplant ILD. We see a lot of organizing pneumonia that tends to be relatively early, as Dr. Weinman showed. And then we see just a smattering of late kind of fibrosis cases or interstitial lung abnormalities. And there's the gray area, of course, with these interstitial lung abnormalities that don't necessarily meet the criteria for fibrosis or any other syndrome. But then there's a lot of people who have restriction and don't really have a clear syndrome. So we are currently taking a look at this with the caveat that this is not yet peer reviewed, but you know, the things that cause restriction beyond interstitial lung disease, you know, interstitial lung disease, mostly we see organizing pneumonia, which is not too surprising. We see very rarely, you know, 1% or less kind of the late fibrosis type of lung disease that we worry the most about. We see some patients who have truncal sclerosis, and even though they seem to have improved range of motion, they continue to have some lung restriction. And this is one of the things that's interesting about truncal sclerosis in the post-transplant setting, is that, you know, you get a lot more of that hidebound chest that you see, and it's associated with a lot more lung restriction than you might see with some autoimmune diseases too. There's, of course, and I think one of the studies I cited pointed this out, there's relapse, of course. We see relapse and that's very different, of course, because once they have restriction associated relapse, their biggest issue is not really the restriction, it's the cancer. But there's a lot of post-transplant just weakness and frailty, and that will manifest as restriction as well too. And of course, like when we think about it, and of course there's infections, but when we think about all of these things, our approaches are going to be very different. You know, in those fibrosis patients, which is a small but significant minority, we might target them towards early antifibrotics and some of the things that we do for fibrotic lung diseases. But for those patients who don't really have a lung issue, they just have weakness. I mean, they're a lot more challenging in terms of increasing their physical functioning, and that goes to some of the things that Dennis pointed out with like just in general improving exercise capacity and rehabilitation and that sort of thing. So that's the complicated thing about the thing that is interesting is that at least in our models, it doesn't really matter which form of restriction you have. They all increase mortality in different ways. So it's not like one is more important than the other. They're all important. They all cause morbidity. And so, you know, but they all require a different strategy. And that's why I think the lung function monitoring is important, because you're not going to pick up some of this stuff unless you look for it. And then once you look for it, you know, once you find it, you have to start thinking about all the many things that can cause it. And so that highlights the need for multidisciplinary collaboration with pulmonologists. It highlights the need for multimodal assessments with imaging and other things like that. So it's an incredibly complex problem, and one that we don't really have a clean answer to yet.
what are you doing for early bronchiolitis obliterans? Are you in terms of treatment or prevention or what?
It's a great question. I don't have I'm not going to have a very formal answer for that, but
I was
yeah,
disappointed when we did the NIH workshop that, things haven't progressed very far in terms of treatment. And so,
yeah, I mean, I'm still a big advocate for home spirometry. I think there's barriers to getting that into patients' hands. It's a low cost device in the context of transplantation, being as expensive as it is, but it's still several hundred to $1,000 to $2,000 to monitor somebody for 3 to 5 years. So there's ways to do it now. There's billing codes and things like that in the US that can help with that, but it's still a challenge to get that into patients. And then there's which patients do we monitor? And so I have some ideas for who would be best to monitor, but when you start focusing like that, you're inevitably going to miss some patients too. And then once somebody develops a lung function abnormality post-transplant, it's not clear which of those are real. The positive predictive value for a single instance of impairment is pretty low, and we showed that a couple of years ago. So there's a need for biomarkers, and that's something that I'm interested in, but there's really not been one biomarker that we found that's going to solve this problem. I think imaging could be a biomarker. We have some early data to show that. But I think those are challenges when we think about how to implement this widely, because ultimately, when we have these studies that I think where sometimes the studies don't translate into the impact that they should have is that the implementation never really goes beyond that study. And so we have some data for these various things, but I think we really need to start thinking about how we can get this into patients' hands and improve the quality of care.
y'all have the photon enhanced CT. Have you heard about that?
Yeah, we have a xenon MRI. We haven't imaged a human yet. I don't want to bore people for the trials and tribulations that we had, but we've had quite a few. And we should be getting a photon counting CT later this year, and that'll be interesting. I'm not yet sure how that's going to translate to this because you do get much higher resolution imaging. I'm sure Dr. Weinman has his hands up, so he can probably tell you a lot more about the photon counting.
Yeah, I'd love his comment about it.
Well, we were actually the second hospital to get a photon counting CT, and I'll say so far we can get lower doses imaging our patients. We can get higher resolution. Sort of combining those things is a little bit of a challenge. When we do the really high resolution mode, the images get really grainy really pretty quickly. So some of those beautiful images take, you kind of have to make that decision. I think down the road, there's the potential to do some imaging with xenon gas or something like that because you have the multi-energy techniques, but that requires sort of a whole nother setup, albeit maybe not quite as complicated as you need to do it in hyperpolarized gas and MRI. So sort of just on the new front of getting that and kind of figuring out some of the nuances of how we can use that to our advantage in these diagnoses.
So some of the data that Jason Woods showed from looking at hyperpolarized xenon and MBW or LCI are correlate pretty well. Like if you find it early in the hyperpolarized xenon, that it translates also to abnormalities in MBW.
Yeah, I think the hyperpolarized gas MRI is great because you save the radiation. The challenging part is it requires sort of a relatively expensive piece of equipment to do it.
Oh no, absolutely. I think I think MBW is complicated, but I think it's cheaper than doing hyperpolarized xenon. Don't tell Jason I said that though. But we should have, so our Transpire study, which has enrolled about 320 kids so far prospectively, and we're about I think we still have 3 more years of collecting data. We'll hopefully tease some of this stuff out. We've done, I think MBW studies we've done, I want to say close to 100, if not more. Oscillometry is about 170 studies, I think. And this will compare to PFTs. So, and then there's MBW, which I think is much, or not MBW, MRIs, but I think that'll be a little bit less. So,
what population?
This is post-stem cell.
Post-stem, okay.
We're trying to find that the optimal biomarker. And in addition to that, we have serial blood samples, which people are looking at different things such as proteomics, and then some of it is just being stored for someone with a great idea to come use it. Cool. But I think we've, maxed out.
Lose everybody. I think we lost most people.
Yeah. Well, this is funny because our normal meetings from 3 to 4, or at least 4 to 5 your time, Eastern time. But we don't have to do both at the same time. Thanks everybody who hung around and spoke, and it was a great session. And look forward to seeing most, or if not everyone, at ATS and anywhere else in between.